Hello everyone, we're ready for another student webinar. It's number 40. Tonight we're going to talk about kind of the basics of E&M coding. I wasn't going to show you any codes actually. We're just going to talk about them. But then I thought, no, in the backup here I've got my find a code just in case I need to reference something for you. But there is so much to E&M if you understand the background, how to find the codes and stuff like that, then all of the more heavy knowledge that comes in. So really, we're going to just talk about the basics tonight. The first thing you need to know about the basics on E&M coding is that it's evaluation management. And whenever a provider looks at a patient, interacts with that patient, they're doing evaluation of the patient's illness, and they're going to manage what's wrong with the patient. So it is in everything it's in every aspect pretty much of what the provider does. So tonight we're going to talk about three main things. We're going to talk about location. And when I say location, I mean where's our E&M codes? Where do we get the information that we need? Why do we need E&M codes? And also the leveling. Now, I'm not going to talk about how to level a established patient with these bullets, et cetera, et cetera. Now, we've got lots of training on that. Again, we're going to talk about the basics, the first things that you need to know when working with evaluation and management codes, or E&M codes. So let's break it down. Location. If by chance you have a CPT manual there in front of you, go ahead and open it up. And one of the things that you'll notice about the E&M codes is that they are at the front of the manual. Now that's pretty telling in my opinion. Why would the E&M codes, which usually start with 99, why wouldn't they be numerically located at the end of the code set? Because you go to 99 codes, but they're not. They're at the front. And then on top of that, if you wanted to divide it up into like categories or even alphanumeric or anything, E&M doesn't fit in that, so it seems odd, first off, that your E&M codes are going to be at the beginning. The guidelines are separate for the E&M codes. So they have their own guideline pages. That's significant, isn't it? We have guidelines for CPT, just like you do for ICD, but E&M's got its own. Now, when you open up that manual and you're looking at the E&M codes, the guidelines for the E&M, the pages are actually green compared to the white for your index and your tabular. Isn't that unique? That's because they want you to be able to see them and determine that, no, this is the guidelines when you're flipping through the pages. Now, all of the E&M codes have that red bar at the edge of the page, okay? And your CPT manual is kind of color-coded that way, but red is what you're going to get with your E&M codes. Red is a color that says, hey, look at me, heads up, right? Or it's a warning. Anything you think about when you say, well, why do they make something red? Well, stop signs are red. If I want to get your attention, I make it in red. Well, again, because E&M codes are important. When you look at the guidelines or those important pages for E&M, they're about every year, it's a little bit different, give or take, but they're going to be about 50 pages, 55 pages. However, if you say front and back, so say you were going to print out your guidelines, it would be a little over 100 pages. I think one year I printed them, they were 111 pages or something, that I needed to take the updated guidelines with me when I was going to take a test or something. So again, you've got about 50, 55 pages of content over E&M. Now, all of those things, you put that together. Why are they in the front of the manual? Why are they color coded with red? Why are they out of sequence? Because they're important. That's the only thing I can think of as to why they do that. And I mentioned before that every time a provider sees a patient, there's probably going to be some type of evaluation and management, or there is some type of evaluation and management that's being done. Even if the patient and the provider don't physically touch each other at that point, there's telemedicine now, and that carries an E&M. They're still doing an evaluation and a management of the patient. So location is very, very telling on our code set for E&M. So why do we need E&M codes? Well, it's how you get paid. Now, you've heard me say again and again, it's like a little mantra, we code for statistical purposes. It just happens to be a convenient way to get paid. It's true that even the E&Ms, those codes are tracked for statistics. However, it is probably the biggest area of the codes, of all the code sets, that determine how much pay the provider is going to get. So again, it's the evaluation and management, the work that goes in is translating it into a code, and then it correlates with a fee. And so E&M coding on every level usually constitutes money. That's what people think about. So when we look at an established patient versus a new patient, established patients don't pay out as much as new patients because the evaluation of what with a first time meeting with a patient, getting to know them, learning their needs, what's their conditions, if they have any comorbidities, looking at their medications, even after you've evaluated them, the management, maybe you have to get content from a previous provider, maybe it's from out of state. You have to have authorization signed to get that information sent to you. Maybe you need to discuss something with the previous provider and consult with them so that you can have a continuity of care if the patient has chronic conditions. So again, a person that a new E&M for a new patient is going to pay out more than an established patient. Now, of course, you have the leveling in there, but we'll talk about that in a minute. Again, it's how we get paid, but every area of medicine involves E&M. Now, some of these I took straight from the code book, divided up in areas that have E&M codes, but every doctor's office is going to deal with E&Ms. It doesn't matter what specialty you are. You could be a general practitioner, you could be a pediatrician, you could be an orthopedist, you could be an oncologist, a cardiologist, a nephrologist. I mean, you could be anything, a podiatrist. There is going to be, even a dentist, you're going to have some area that is going to have codes for E&M for that, maybe even for a subspecialty, I guess, if we say like newborn services, things like that. But every time a doctor sees a patient, an E&M code is going to most likely be used. Consultations, they, again, same thing that E&M would be, but a consultation is different in that you're not taking over the care of the patient. So let's say we have a new patient from out of state, and they're diabetic, and the doctor does a new setting up care for the patient, and they do their initial E&M for a new patient, and then they come back and then they start having problems with their feet, and the doctor says, you know what, I want you to consult with a podiatrist because I think that you need to have your feet looked at since you're diabetic. And so they do a consultation with a podiatrist. Now, the podiatrist may take over the care of the patient's feet, or they may just render an opinion. Most of the time with a podiatrist, if it's a diabetic, they'll take over the care for that. A cardiologist isn't going to take care of the patient's feet if they're diabetic, although if they're having issues, peripheral circulation is being affected, and that'll affect the heart, and they may be seeing the cardiologist. But they're not taking over the care for the feet. The podiatrist does that. So again, let's say the doctor thinks they hear an arrhythmia. And he says, you know what, I think we need to get a consult with, Dr. Corazon. And so he sends him off to the cardiologist to have him checked. And the cardiologist says, no, everything's fine with the heart. I checked it out. Thank you for the consultation. Sending them back, and saying, no, he doesn't need my specialty care, but let me know if you have any other questions. This was like a one-time thing. Maybe they drank too much caffeine or something. So it was a consult. But consults could turn into regular them taking over the care like a podiatrist. And so the podiatrist would then do their own E&M leveling for that patient. See? Okay. So what about ER? ER is a temporary environment. You're supposed to get them in, determine what the trauma is or the issue is. Are you going to put them in the hospital, or are you going to send them home and let them see their regular provider? Maybe you think of a child, it's in the middle of the night, they start having breathing problems, and the parents are worried, the child's wheezing, and they get scared. They take them to the ER, they do a breathing treatment, make sure that it's not RSV, or that the child doesn't have ear infection or pneumonia. And they said, no, this is something that the breathing treatment relieved the wheezing for the child. Follow up, maybe write them a script. Now you need to take your child to the pediatrician and let them take over care, right? It's an emergency situation. It's not meant to be long term. Then let's say the same child, though, they go in, they said, man, they just had a stuffy nose, and then all of a sudden they started this wheezing, and they've got this cough, and we're really concerned. And now she's got a fever, and they run some tests, and they say, yeah, they have RSV, and they put them inpatient. Okay, but still, the ER itself is a temporary location. They have their own set of and management codes. We also have skilled facilities. Very seldom are these in-house, attached to the hospital. There are some step-down floors and some unique scenarios that hospitals get into. But usually a skilled facility will be someplace that the patient goes to for a specific length of time. It's not a one-time visit. It's not, just a day or two. It's usually a week or a month while the patient's recovering and then preparing to go home. So they're not sick enough to be in the hospital, but they're not well enough really to go home yet. So skilled facilities tend to be a transitionary area, unless it is something where they're going to need full-time care and they don't have another place to go home to, like a nursing home, and sometimes they call those skilled facilities. They have evaluation and management codes in and of themselves because the provider comes to them. They don't have a full-time staff only provider. The provider comes in and there's E&M codes for that. E&M codes cover all age groups as well. So you can have a new or established patient, and they be a newborn that is doing their first visit with a provider at, like their 6-week follow-up. Or it could be a toddler. It could be all ages. It could be teenager, it could be a person in the prime of their life, it could be a person that just turned 65 and is going on Medicare, or it could be an 80-year-old patient that's considering hospice. So all age groups are affected and by E&M coding. There's not a niche. Now there are niches within the E&Ms, like the newborn services, but we'll get to that. Prolonged services, things that are above and beyond what is normal or standard. We have codes for that because there's always an exception to a rule. So it should take X amount, they should be able to get you in, get you out, do a procedure, and it's expected to take 30 minutes, but they run into some scenario that the services are prolonged. And so, the evaluation and the management literally took longer than normal. Okay, so there's their own codes within the E&M section for that. We have case management. So there's more than one type of case management. You could do it as a single or a group. Let's say you have a patient that's getting ready to go home. They've been in a severe, they have severe injuries from a motor vehicle accident. They are now a paraplegic. They had a head injury, and that's still, in healing with and stuff. But they have to learn how to work their life in a scenario that they never thought that they'd have before, because they've got two limbs that no longer work. So you're going to have several people involved in the care of that patient. You're going to have the provider, you're going to have a neurologist, and you're going to have maybe even an orthopedist involved. If there was fractures and things, you're going to have a social worker, you're going to have PT, OT, and ST, probably not ST. Well, you could, if there was a head injury, they could have ST. And all of these people, entities, are going to work together to manage the care of that patient on a case level. So when they go from ICU and then they go to the floor, and then they get therapies on the floor, and then when they can transfer into a rehabilitation center, and how they start when they get to the point where they can go home, and then they come in for rehab, or they have rehab taken to their home, and all of this stuff is being managed, and there's E&M that works with that. Telemedicine isn't actually new. We talk about it a lot more than we used to, but that's because it never got paid before. But telemedicine has been around for a long time, and there are specific E&M codes that we use to get reimbursement for telemedicine. Newborn services are unique, and so therefore there are E&M codes for newborns alone. Then of course we have inpatient and outpatient codes. Outpatient probably we're the most familiar with, or is talked about quite a bit, because that's your 99211 or 99111. That's where you see your 1, 2. The outpatient is the new patient or the established patient, and it's easy to write test questions on those. You use those a lot. But with inpatient, it's a little bit different, because you have initial, you have subsequent days, but still the provider is coming in every day and doing an evaluation of the progress of the patient, setting up prognoses and managing the care every single day. So therefore they should be reimbursed for that. So the need actually is very, very high, right? We can see how that it involves every area, every aspect of medicine, and that we want our providers to get paid, and this is the easiest way to come up with compensation for the evaluation of what's wrong with the patient, and then the managing of how to treat them. Next, we really need to talk about leveling. The leveling aspect is, we see that more with the outpatient. that I mentioned a little bit ago. And it's easier to teach someone the leveling in that uh, because it's easily defined. They are ultimately, uh, for the work that's being done, the patient or the provider's being reimbursed. If a patient has one illness, let's say they have an ear infection, they come in, they're seen by the doctor, it's pretty basic, they just need an antibiotic and Tylenol for fever and good prognosis that they'll get better, and that's it. Nothing else wrong with the patient. That is not going to be reimbursed in the same level as a provider that's seeing a new patient, not an established patient, but a new patient that has, 3 chronic conditions: diabetes, COPD, and pulmonary hypertension. Okay, that's that, and they've got a current lesion on their foot that's probably a diabetic ulcer and need to be evaluated. We need to set up a consultation with a podiatrist and uh, uh, and establish information care, continuing of care from a previous provider that in another state, the example I gave you before. And we're not just talking about the one provider, the PCP, but probably they saw a podiatrist and a cardiologist and et cetera, in their other facility. Maybe they've been an inpatient before and they had a previous amputation of a toe. And, wow, that person is going to need a lot more evaluation and management of care than another person that has an ear infection. And thus, those magic numbers of the leveling 1 through 5 is going to be higher. We have more chronic conditions, and the provider should be reimbursed at a higher level for that care for that patient. It's not a flat across the board. Every time I see a patient, I get paid $50. No, because if you did that, it's going to take you 10 minutes to take care of the patient that has the ear infection, but it's going to take you an hour to take care of the patient that has multiple chronic conditions and exacerbations. So again, I don't want to say it's a no-brainer, but it makes sense, right? That's the E&M, the leveling. Those magic numbers are 1 through 5. So if we use those an example of um, uh, a patient coming in, being supervised by the provider, but they're just coming in and getting their flu shot from the nurse, it's going to be a 1, right? If it's an established patient, it's a 99211. If it's a new, it's well, you probably wouldn't have a new patient. I mean, it'd be a different scenario. But let's say it's a new patient and they have one chronic condition, that needs to be taken care of. Well, then it's going to be a 3 or a 4 probably. It could be less, but if they have a chronic condition, then you're probably going to end up with a 3 or the 4. Whereas if you have a patient, whether they're new or established, and they have 3 chronic conditions that have exacerbations, well, it's going to be a 4, and depending on how sick they are and how much has to be determined and how many body systems that have to be reviewed, et cetera, it's going to be a 4 or a 5. Other types of leveling, though, it's not all about 1 through 5. 1 being ultimately a patient that's not as sick as 5 being a patient, hey, this patient's really sick, and it's possibility we're going to send this person to the hospital. Sometimes it's based on age. So the leveling is based on how old the patient is, especially when we have newborns and things. There's other times when the leveling is not done via those magic numbers 1 through 5. However, it's based on time, how much time that the provider spends with the patient for prolonged services, for example. It can be divided up into increments of 15 minutes. So keep in mind that most of the time you're going to be tested on those magic numbers, the 1 through 5. You just have to determine whether it's a new patient or an established patient, and then how many body systems, if it's history, all of that's all factored in. And that's what we spend a lot of time teaching about with E&M coding, is that leveling. But there is other areas that constitute how we level an E&M, and that could be age and time, for example. There's others too, but those are the main ones. Let me go back here. I didn't want to stop yet. I will show you these codes. Let's see if I can just pull this over. Oh, hold on. I don't know if I can get that to, no, hold on here. Just take a moment. This is the established patient E&M evaluation management. And remember, I told you started at 99211, and then it goes all the way down to 99215. All right. After that, then we start looking at things like hospital observation, subsequent hospital observation, and just notice how these are numerical. But not all of the E&M codes are numerical. So look at consultations. Again, pretty numerical, right? We go 3-9, then we get into consultations, then we get into inpatient consultations. Emergency department jumps from 99255 to 99281. Okay, then critical care. And then look what we get. Nursing facilities, 99304 to 99306. Okay, so see how we're not in, well, I guess there's no other codes there. So, but they jump around because they're divided up in these sections. Nursing facility discharge, there's only 2 codes and it's based on time. So if we're discharging a patient from the nursing facility, if we spend less than 30 minutes, we've got one choice. And if it's more than 30 minutes, it's another code. Pretty simple. It's based on time. And then let's see, let's jump down to some other things. Prolonged services that I mentioned before. And again, they are based on typical service time for a primary procedure. And then there's several other codes that you can use for that. Case management services. Well, looky here. There's only two codes. So you either have the one that is, they're both face-to-face, but it's a medical team conference, all right? And it could be with the patient or the family. This is all the same, but look here. It says 30 minutes or more, participation by non-physician qualified healthcare provider. This one is 30 minutes or more. And then look what makes this different right here. Participation by the physician, participation by non-physician. Okay. And we can go on, but I'm not going to show you more of those. These are, the way we're going through them now is how they're set up in the E&M section. All of these are considered evaluation and management codes, right? Well, look again, another time-based counseling risk factors, right? Time-based, preventative medicine, work-related, disability evaluations, newborn care services, again, that is unique. And then delivery, inpatient, general behavioral, things that you probably didn't even realize if you're new to coding, that E&M covered all of this. Advanced care planning. Now, when we're talking about advanced care planning, then you kind of think of an advanced directive, but we're we're trying to decide or help the patient and the family decide end of life care, and there's only two choices there for you. Okay, that's because this is an add-on code. So really there's one code, and if you exceed the time, then you get two codes. And that's about it. Okay, so you are going to now know a little bit more about the codes themselves, the E&M codes, why we use the E&M codes. It's based on the provider needs to get reimbursed for the work that they do. And ultimately it's divided up into different categories so that we can establish that they're based on more than one thing. It could be based on leveling, it could be based on time, it could be based on age. Again, you don't have to have this memorized. It's all in that description and that first area of your E&M or your CPT code book. If you have any further questions about this, and I'm not seeing any questions off to the side, know that you can go to the CCO.us /club. You can join the club, ask your questions there, and you can also check out some of the special training that we do for E&M. We've done them on our YouTube channel, Medical Coding Cert, and if you're in the club, we have a lot of special training on E&M. So we just talked about the basics. We didn't go into a lot of detail about coding them or coding out scenarios. This is a basic overview of why we use E&M. Looks like we did have some questions come in. Okay, Amy says, we're getting denied when we bill 99222. And hold on, it went really fast. We're getting billed 92, and the hospital also bills 99222. Okay. I don't know. I probably can't answer you on that question tonight because I just turned off my encoder and it probably won't let me bring it up. But that is an excellent question, Amy, for the club. We have several subject matter experts that can help you with that. And our Jennifer, who is a billing expert, may have some insight that she can share with you. If it's something that you would like us to do some training on, we can do that as well. Send in a topic request and I'll get even more information and we'll do a webinar on just that code, especially if you can give us some scenarios. Whitney asks, does a provider have to be credentialed with the organization to provide telemedicine services? Yeah, I think so. For example, a provider at an internal medicine clinic providing telemedicine services for the state prison. Okay, the state prison is different. I did go to an amazing lecture. I think that was I started to say it was in Corpus Christi, but no, it was in the New Braunfeld. We were in Seguin. It was the New Braunfeld chapter, their Maymania. We had an excellent speaker come in and talk about telemedicine and how it works in the prison. Fascinating. I still have her card. They have been doing telemedicine for a long time, and in Texas, they're actually one of the leaders in telemedicine with prisons, and she's been with the system for over 20 years as an RN case manager. So if I tell you in that scenario with a prison, usually what happens is they are linked with a facility. Okay, so the prison is going to use one facility, let's say Baylor Scott and White, which is a big group here in Texas. So the Texas State Penitentiary will use the Baylor Scott and White Hospital close to them, and all of the providers will come from Baylor Scott and White. So again, that kind of usurps the credentialing process, but they're not going to get any telemedicine from a provider that hasn't been credentialed in that state or credentialed with the facility that they're using. I can say that with confidence. But they usually stick with one facility, unless say they have oncology, and then they may use a Baylor Scott and White oncologist, or they may use one out of MD Anderson or something. There's another one. No, hold on, I'm getting them mixed up. If a patient has an acute upper respiratory infection, would you say this meets the criteria for a 99214? They were prescribed just one medication. It really matters more. Okay, there's kind of a school of thought that if a medication is prescribed, it's automatically level 4, right? But actually, no, because they could prescribe a medication for if a patient comes in with an ear infection, okay, perfectly healthy patient, they're going to prescribe an antibiotic. They didn't look at any other body systems. Is it really a 4? Um, whereas you could have another patient that comes in with an ear infection, but there is, let's say they come in with an ear infection, but they're 80 years old. Okay. Oh, wait a minute. Now, maybe they don't have any other comorbidities and they're not being seen for anything else. Maybe they're perfectly healthy. However, what you do for a 6-year-old with an ear infection and what you do with an 80-year-old with an ear infection, that's going to be different, right? So, yeah, that would be 4. There's really more into it than just saying I wrote a prescription and therefore it's a 4. An acute respiratory infection, sometimes acute respiratory infections get better on their own. Not always, but they can. It's going to take longer. But if you've got a patient that has nothing else really wrong with them, it's not a problem. So, it really depends on the documentation, and I would never say a prescription gives you a 4. You have to look at the other information that's in there. But yeah, acute respiratory infection with a with a prescription, yeah, could be, could still be a 4. Whitney says, what if the patient comes to the ER is admitted for less than 18 hours or 8 hours for an observation and transferred to another hospital? Would you have to code this as an ER visit, not an observation? I may have to put my glasses on to see the rest of that. Hold on. What do I do with my glasses? I had them on top of my head before we started. There they are. I'm sorry. Okay. Yeah. All right. So if the ER visit, not an observation since they didn't meet the criteria for number of hours to be charged an observation code. Yeah, you really need to see the documentation on this. But yeah, it would probably be just an ER visit. I could be wrong. I know I'm not giving you a definitive answer, but I'd want to see the scenario. I wouldn't use that as a test question, for example, without a little more information in there. It's a good one, though. Good question. I think that's it. You guys are great. So these questions are fabulous. This back and forth, excellent. And if you want to put questions like this in the club, we even have the free forum. If you're not ready to commit to the club yet, you can do that. This would be a good one, Whitney. If you can give me a little more details on a scenario, I can put some more information about ER visits that turn into a transfer to another hospital. And there's a lot of reasons why that happens. I used to see that happen all the time working in when I worked in the ER, because we were a level 3, level 4. We were a level 3 trauma center at a very small hospital. We would have been a 4, but we didn't have a neurologist on staff, and we saw some really unique scenarios. But the hospital itself wasn't equipped to take some more critical patients, and so they would fly them out to the university hospital. They got transferred quite a bit, you know. Again, interesting. I like anything that has to do with ER. All right, thank you very much, guys. We're a little bit shorter than we normally are, but that's okay, right? And I'll see you tomorrow with our CCO Live. And then again, let's see, I'm not sure what we got going on the rest of the week. I have to look at the schedule, but I'll see you again soon, I'm sure. Bye, guys.